Good evening, everyone, and thank you for joining us to learn more about JYNARQUE, the first FDA-approved treatment for ADPKD. My name is Nicole Haar, and I will be your host throughout this presentation. We will begin the presentation in just a moment, but first I have a few announcements to assist you in participating in tonight's broadcast. I would like to thank the PKD community for submitting questions ahead of time for the webinar. Questions were provided to Dr. Perrone, and he will cover many of the questions we received during his presentation. We encourage you to type any questions you may have during the presentation into the question box on the right side of your screen at any time during the webinar. There will be time to answer questions during a Q&A session at the end of the webinar. However, we may not get to all of the questions submitted. Your questions are important to us, and we will continue to update the FAQs posted at pkdcure.org as we receive more information. We will be tweeting during the broadcast. Please join in the conversation on Twitter using the hashtag ADPKD. We know that you have lots of questions and concerns about pricing and accessibility of this treatment. We at the PKD Foundation are working with Otsuka Pharmaceuticals to advocate for affordable access to this treatment for any patient who is determined appropriate to receive it. Otsuka offers a number of support programs for eligible patients, including the JYNARQUE Copay Savings Program, which is intended to allow eligible commercially insured patients to not pay more than $10 per prescription. Further information about program limitations and legally required exclusions are available at www.jynarque.com/copay-savings. The Otsuka Patient Assistance Foundation, or OPAF, a separate and independent entity, provides support for eligible patients who are unable to afford their medication. OPAF's mission is to eliminate financial barriers to drug therapies for uninsured or underinsured patients. For more information, please visit www.otsukapatientassistance.com. The PKD Foundation will continue to meet with Otsuka's patient assistance team to better understand all of the various programs to ensure affordable access. More information will be posted once the product becomes available. Although we are referring to the treatment by its brand name, JYNARQUE, this webinar tonight and all information provided about this treatment is independent from Otsuka Pharmaceuticals. It is intended to be an education and informational discussion and should not be taken as a product promotion or endorsement. The PKD Foundation does not endorse any specific brand, company, or treatment. We are here to support patients, provide factual information, and fund medical research. The statements made in this webinar by Dr. Perrone are his statements alone. They do not represent and are not influenced by Otsuka Pharmaceuticals or the PKD Foundation. Please note that the PKD Foundation does not offer medical advice, and the information shared this evening is not intended to be a substitute for consultations with your health professionals. We strongly recommend that care and treatment decisions related to your health concerns be made in consultation with your health professional team. To get us started, I would like to introduce Dr. David Barron. Dr. Barron is the Chief Scientific Officer at the PKD Foundation, and he is going to introduce our presenter. David?
Thank you very much, Nicole, and thank you to all of the patients out there who have participated in the various clinical trials that have led to the approval of JYNARQUE by the FDA. We really appreciate your participation in these trials, and without you, these types of drugs would have much more difficulty in being developed and approved. And this is the first specific treatment for PKD approved in the United States. And we'd like to also thank the hundreds of clinicians and researchers from the beginnings of the foundation over 35 years ago, and on to this very day who are still working on this challenging disease. Of note, we'd like to extend our sincere gratitude to Dr. Vicente Torres of the Mayo Clinic, Arlene Chapman of Emory, and more recently as Section Chief of Nephrology at the University of Chicago, Frank Serwick at Otsuka Pharmaceuticals, who has led the clinical program for Otsuka, and of course, Dr. Perrone, who is here with us tonight and will talk about this exciting development. Dr. Perrone, as many of you know, is Scientific Director of the Clinical and Translational Research Center at Tufts University, and he's also Associate Chief of the Division of Nephrology there. And he's the Medical Director of Kidney Transplantation. He's also a Professor of Medicine. Dr. Perrone is board certified in nephrology and internal medicine, and he's received numerous honors and awards, including Top Doctor from Boston Magazine for several years, the Physician of the Year Award from the Polycystic Kidney Disease Foundation, as well as rather recently the Kaplan Award from the foundation as well. He is involved in, as I mentioned, transplantation, and serves on the Scientific Advisory Committee for the Optum Immunos Kidney Transplant Committee in Region 1. He's also on the editorial board of the Clinical Journal of the American Society of Nephrology. Dr. Perrone has a long-standing and wide-ranging interest in autosomal dominant polycystic kidney disease, including basic investigations addressing the mechanisms by which the disease causes cysts in the kidney, and clinical investigations that describe the reasons for mortality and the requirement for renal replacement therapy. He has really been pivotal in directing research that has resulted in the approval of JYNARQUE, and I'm excited to hear, along with the rest of you, his talk on this newly approved drug.
Okay, Dr. Perrone, I'm turning the presentation over to you.
Thanks, David. Thanks, Nicole. I'm pleased to talk about JYNARQUE, or tolvaptan, which was the first FDA-approved treatment for ADPKD. I'd like to reiterate the gratitude that Dr. Barron mentioned. Thanks to the many participants around the world who have participated in TEMPO and REPRISE, and a number of other clinical trials, HALT, TAME, Overture, Nocturne, Phoenix, Cadman, and others. No advances are possible without research and clinical trials, and the success of this therapeutic agent is a tribute to everyone who has participated in the trials and its development. Just to refresh your memory, TEMPO 3-4 and REPRISE were both worldwide trials. TEMPO had 1,445 subjects from 29 sites in 15 countries. REPRISE had 1,370 subjects from 213 sites in 21 countries. And you can see the countries, many different continents around the world. The other thing I would point out, clinical research is a collaborative endeavor. I am speaking on behalf of many other study investigators. So I've listed the TEMPO 3-4 and the REPRISE steering committee members on the slide. Dr. Torres, Dr. Chapman, Olivia De Woest from Brussels and Zurich, Ron Gansevoort from the Netherlands, Jared Grantham, who unfortunately has passed away, Dr. Higashihara from Japan, and the very competent and capable Otsuka team, Holly Kresa, John Ouyang, Osama Saito, Frank Serwick, Lori Dubuque, Jamie Bly, and Dorothy Oberdon, and more than 200 site investigators. So just to mention, autosomal dominant polycystic kidney disease is a hereditary systemic disorder with bilateral kidney cysts with a progressive decline in GFR, or glomerular filtration rate, leading to kidney failure in 50% of patients by the 6th decade. It includes extrarenal manifestations, including liver cysts, brain aneurysms, and heart valve issues. And this is obviously a very severely affected and end-stage polycystic kidney. Now, in order to sell medication in the USA, it must be approved by the United States Food and Drug Administration. It must be safe and effective. And based on the Kefauver-Harris drug amendments passed in 1962, one has to provide substantial evidence necessary from adequate and well-controlled clinical trials that form the basis for drug approval. So going back a long time to 2003 and earlier, just to show you why we think vasopressin is an important player in polycystic kidney disease, in these series of slices of rat and mice kidneys, the control is shown on the left with lots of holes or cysts in all of these different models. And when given a drug very similar to tolvaptan, this largely prevented the development of cysts or markedly reduced the development of cysts. If you, in this upper right panel, if you give rats water with sugar in it, they like that. And in this particular species of rats, drinking a lot of water resulted in a marked reduction in cystogenesis in both male and female rats. But the most elegant evidence for the role of vasopressin in cystic kidney disease is this experiment where rats containing the PKD gene were bred with rats that lack the gene for vasopressin. And these middle kidney slices in here are from rats that have polycystic kidney disease but have no vasopressin. And you can see they have virtually no cystic kidney disease. Whereas the same rats, when they have vasopressin, either naturally or when administered, have fairly severe cystic kidney disease. So this is very compelling evidence. So we reviewed the TEMPO 3-4 and REPRISE results previously. These papers have been published in the New England Journal of Medicine, and a webinar reviewing these results in detail was done on November 13th, 2017, and they may be found on the PKD Foundation website. So I'm only going to quickly review these studies. TEMPO 3-4 looked at the effect of tolvaptan on total kidney volume. And in subjects in the early stages of ADPKD, tolvaptan decreased the rate of total kidney volume growth by half over 3 years. And tolvaptan treated individuals are shown in the blue line, and placebo treated individuals are shown in the red line. Now the effect of tolvaptan on eGFR, or estimated GFR. This was done in both the TEMPO and REPRISE studies. And tolvaptan slows the rate of eGFR decline across a broad range of disease states. In REPRISE, the most recent study, tolvaptan decreased the rate of GFR decline by 1.3 mLs per minute per 1.73 meters squared. That's a typical body size. This was a 35% decrease in the rate of GFR decline over 1 year. In TEMPO, the average yearly rate of benefit was 1.2 mLs per minute, and this was a 34% change. So in both TEMPO and REPRISE, tolvaptan slowed the loss of kidney function by 1.2 to 1.3 mLs per minute per year. And taken together, these findings support a disease-modifying effect of tolvaptan in ADPKD at various stages of disease. Well, what were the safety results? The safety profile of tolvaptan was similar across both clinical trials. The most commonly reported tolvaptan-related adverse events were mild to moderate in severity and associated with increased production of urine. About 8% of participants discontinued their participation in the study accordingly. And while elevations in liver enzymes were more frequently reported in tolvaptan-treated subjects, between 4 and 6%, the risk of more serious liver injury was mitigated in the REPRISE trial with stringent or close monitoring and timely discontinuation of treatment. This slide compares the elevations of the liver enzyme ALT in the two pivotal trials. And in both studies, more patients who received tolvaptan than those on placebo experienced an elevation of the ALT more than 3 times the upper limit of normal. In the REPRISE trial, this was 5.6% of the tolvaptan treated patients versus 1.2% of the placebo treated patients. And these findings were consistent with the TEMPO 3-4 study. So shown here, about 5.6% of patients in the REPRISE study experienced an elevation of their ALT more than 3 times normal. And in the TEMPO study, 4.4% of the patients experienced elevation of their ALT more than 3 times normal. In the REPRISE study, there were no additional cases meeting severe criteria. There were 3 in TEMPO. And the difference is this is likely due to more frequent monitoring, that is on a monthly basis. In TEMPO, the monitoring was every 4 months. I'll come back to this slide a little later. So I'm sure you have many questions related to what, who, when, and how. And this slide is an outline of what I'm intending to cover next. So what are the indications? That is, what is the FDA indicated on the label, or the basically the instructions of who this drug should be given to, of who should take tolvaptan. And I'll go through these in more detail, but we need to consider age, GFR, total kidney volume. And FDA has indicated that tolvaptan should only be given to people who have rapidly progressive disease or a high risk of progression. When is tolvaptan available? How do you get it? And then I'm going to talk a lot about the REMS, the risk evaluation and mitigation strategies that are in place to prevent the development of severe liver injury. And essentially, liver function tests are obtained at baseline, at 2 and 4 weeks, and monthly for the first 18 months, and every 3 months thereafter. And the drug is dispensed by a specialty pharmacy only after liver function tests are reviewed by your physician. So let's go through these in more detail. So what are the indications? This is directly off the package insert, the prescribing directions that are given to physician. The JYNARQUE is a selective vasopressin V2 receptor antagonist indicated to slow kidney function decline in adults at risk of rapidly progressing autosomal dominant polycystic kidney disease. Well, that's all we've got. The FDA didn't define rapidly progressive polycystic kidney disease. So I'm going to give you my take on this, and this is an opinion shared by many people who worked on the tolvaptan studies, both in the United States and around the world. So large kidneys at a young age are a risk factor for rapid progression. And there's many different ways to determine this. And I'll go through the Mayo Clinic imaging classification, where classes 1C, 1D, and 1E are more severe and are associated with rapid progression. An average kidney length greater than 16.5 centimeters, and this can be done by ultrasound, CT, or MRI. In addition, the TEMPO 3-4 criteria required a total kidney volume greater than 750, ages between 18 and 50, and a creatinine clearance greater than 60. And then in REPRISE, the entry criteria are ages 18 to 55 years with an estimated GFR between 25 and 65. There is an older group entered in REPRISE, and it's not clear if this is a high-risk group because they didn't benefit a great deal from the therapy, and there's a lot to talk about there, but I would suggest that these are criteria that you and your physician could incorporate to decide whether or not you meet the criterion of rapidly progressive. Another way of determining risk of rapid progression is a DNA mutation analysis. And this involves measuring the type of PKD mutation, that is PKD1 or PKD2. Our colleagues in France have incorporated these measurements of DNA mutation into a score called the Pro-PKD score, and I'll go through that in some detail. Another finding that may be consistent with high risk of progression is the development of end-stage renal disease in a first-degree relative before the age of 55. And this is suggestive of PKD1. So if a parent or an aunt or an uncle had ESRD before the age of 55, that's suggestive of PKD1. Other risk factors which need to be taken into consideration are that men do worse than women People with significant pain issues and kidney bleeds might also be exhibiting a risk of rapid progression. I just want to make it clear you don't need to have a DNA mutation analysis. That many of us who work with tolvaptan think that the measurements of total kidney volume would be perfectly adequate to sort this out. So this is a slide that shows the Mayo imaging classification. And the way to look at this is if you're a young person with large kidneys, it means your kidneys grew very fast. And having a height-corrected total kidney volume of less than 200 or so is normal. So if you're 60 years old with relatively small kidneys, you're in class 1A, and you really have a very low risk of progression, and you probably shouldn't take tolvaptan. On the other hand, if you're 40 years old and you have a height-corrected total kidney volume of 2,000 cc's, you're at high risk of rapid progression. And I'll show you how these translate into GFR decline. So again, this top line is normal. There's a small age-related decline in kidney function. Class 1A and 1B have a slower rate of progression, but classes 1C, 1D, and 1E have a faster rate of progression. So for example, if you're class 1E and you start out at 70, you might have kidney failure in between 10 to 14 years. Your physician can estimate your kidney volume from measurements taken from a CT, MRI, or ultrasound. They don't need to be the same exacting measurements that are done in research studies. This is work from our French colleagues, Emily Cornac-Legault, showing the effect of genotype. And I'm sorry, these definitions here are shown in French. What they mean is PKD truncating mutations. So this is a mutation which leads to a complete absence of polycystin 1 protein. And PKD1 non-truncating mutation is one which results in a small amount of active polycystin protein. And so if you have a PKD1 mutation, this results in a much lower kidney survival. So that means about half the people have lost kidney function by the early 50s. If, on the other hand, you have a PKD2 mutation, it takes much longer for half of those individuals to lose kidney function, namely in the 70s and 80s. So genotype can be predictive of the future development of loss of kidney function. What our French colleagues did was they developed a point system, including the genotype and several other factors, to devise a system for understanding the risk of end-stage renal disease. So male gender gave you 1 point, high blood pressure before the age of 35, 2 points, first urologic event before age 35, 2 points. First urologic event might mean an episode of gross hematuria, a kidney stone, a cyst pain. And it's important to realize that the early onset of hypertension and urologic events are primarily related to kidney size. So these are proxies for enlarged total kidney volume. PKD2 mutation gives you 0 points. Again, a non-truncating PKD1 mutation, 2 points. And then the most severe mutation, PKD1 truncating, gives you 4 points. And they divided these into categories of low risk, intermediate risk, and high risk, and predicted the age of development of ESRD. So if you're low risk, the half of the people would get kidney failure by about age 71, whereas if you're high risk, half of people would get kidney failure by the age of 49. And then these curves are divided into high risk, intermediate, and low risk. And certainly the effect of the mutation is very important. But if you're high risk, the median age of kidney failure is actually now 49 or 50, much younger than it was when you just look at the genotype alone. So this is another way of stratifying risk. Again, if genotype is available, it's certainly reasonable to review that, but it's not necessary to go out and get that measured. What's it like to take tolvaptan? It's taken twice daily with doses separated by about 8 hours. One takes the larger dose in the morning and a smaller dose in late afternoon or early evening. This is done to try and limit the amount of sleep disruption that occurs by producing large amounts of urine at night. But there's no question tolvaptan results in the production of large amounts of dilute urine. This results in urinary frequency, large urine volumes, and nighttime urination. How do I manage life on tolvaptan? The loss of fluid also stimulates intense thirst and necessitates ingestion of large quantities of water, 4 to 6 liters per day. And everyone who's taken tolvaptan will tell you that thirst drives their fluid intake. It clearly makes water taste better, and it's very important that you satisfy that thirst by taking in large quantities of water. And I've indicated here, not diet soda, tea, coffee, Crystal Light, etc., but water, large amounts of water. So tolvaptan must be held at times when fluid intake cannot be maintained. So when you're sick, when you have nausea, vomiting, or diarrhea, when you're doing a colonoscopy prep, when you're dehydrated for any reason, you need to hold the tolvaptan. So when is tolvaptan available? I've been told it will be available on May 25th for patients. However, prescribers and patients must sign up on the REMS website. And the REMS website is not open yet. This link I've shown here for the REMS website is currently under construction. So again, let's go back to the ALT elevations. Just as I showed you before, about 4 to 6% of individuals experience elevation in their liver enzymes more than 3 times the upper limit of normal in reprise, and this was similar to that in tempo. This was monitored with more frequent monthly monitoring, and there were no severe elevations in the reprise study. It's important to point out that this elevation of the ALT is not related to liver cysts or polycystic liver disease. The liver cysts derive from the bile ducts, which are within the liver, and the liver injury that is seen with the elevation of the ALT is an effect on the liver cells, not the bile ducts. So again, no relationship to liver cyst disease. So this is basically a screenshot of the risk evaluation and mitigation strategy for REMS. And this is like the first thing you see on the package insert. JYNARQUE can cause serious and potentially fatal liver injury. Acute liver failure requiring liver transplantation has been reported. So measure liver enzymes, ALT, AST, and bilirubin before initiating treatment, at 2 weeks and 4 weeks after initiation, and then monthly for the first 18 months. Prompt action in response to laboratory abnormalities, signs or symptoms indicative of hepatic injury can mitigate but not eliminate the risk of serious toxicity. And because of the risk of serious liver injury, JYNARQUE is available only through a restricted distribution program under a REMS. So from the physician's perspective, at the onset of signs or symptoms consistent with hepatic injury, or if ALT, AST, or bilirubin increase to greater than 2 times the upper limit of normal, immediately stop the JYNARQUE, repeat the lab test as soon as possible, that is within 48 to 72 hours, and continue testing as appropriate. If laboratory abnormalities stabilize or resolve, JYNARQUE may be reinitiated with increased frequency of monitoring as long as ALT and AST remain below 3 times the upper limit of normal. So and the other instructions are to do not restart JYNARQUE in patients who have experienced signs or symptoms consistent with hepatic injury or whose ALT or AST ever exceeds 3 times the upper limit of normal during treatment with tolvaptan, unless there is another explanation for liver injury and the injury has resolved. For example, ingestion of large amounts of alcohol, development of infectious hepatitis, ingestion of large amounts of Tylenol can also cause liver injury. And if you happen to have very low levels of AST or ALT, an increase above 2 times baseline even if it's less than 2 times the upper limit of normal, would warrant the same kinds of reaction. How do I get tolvaptan? The physician needs to sign up on the REMS website. The physician needs to determine that you are at high risk for progression. Not everyone is at high risk for progression. You will also need to sign up on the REMS website, and you will need to have measurements of liver function test at 2 and 4 weeks, and monthly for 18 months, and quarterly forever, which must be reviewed by your provider. For those people already taking tolvaptan as part of the TEMPO and REPRISE studies, they will be able to indicate their study status. And since they've all had the 18 months of close observation, they should be able to go to continue the quarterly measurements, which they're presently doing. But that only applies to people who are in the actual studies. So tolvaptan prescribing. You're not going to get this at your local pharmacy. Prescriptions will be managed by 3 specialty pharmacies, mail order only. The pharmacy will verify through your provider, who will attest that liver function tests have been done and are in range, and only then the pharmacy will release the medication. No blood, no drug. So I'm winding up now and be happy to entertain your questions soon. This is only the beginning. The approval of tolvaptan represents the beginning of a new era for treatment of ADPKD. The future is bright. I believe Nicole will field questions, and I'm happy to answer as many as I can.
Yes, I'm here. Thank you so much, Dr. Perrone. We have lots of questions coming in tonight, and we will do our best to either clarify some of the ones that have been asked really frequently and also ask the new questions that we're receiving. So the first question I have for you is, will tolvaptan slow the growth of cysts on the liver?
It's an excellent question. Tolvaptan should not have any effect on liver cysts. That is, and the reason tolvaptan works in the kidney is because kidney cells have a receptor for vasopressin. The bile duct cells do not have that receptor, and we would not expect any benefit nor harm.
Okay, thank you. Next question is, will having liver cysts make the risk of liver injury worse?
There are many people in the TEMPO and REPRISE studies that have liver cysts, and in the TEMPO study where we actually measured kidney and liver, we measured kidney volume, we also measured liver, there was no association between liver cysts and liver injury.
Okay. Next question, what if my doctor will not prescribe this to me?
Well, if your doctor will not prescribe tolvaptan, it's important to find out why. So if your doctor will not prescribe tolvaptan because the doctor doesn't believe you have rapidly progressive or high risk of rapidly progressive kidney disease, then I think that's a reasonable answer. And you can always get a second opinion, of course. If your doctor won't prescribe tolvaptan because the doctor doesn't believe in tolvaptan, or for whatever reason, or doesn't want to deal with the REMS or whatever other reason, then you might seek another physician in your area who would be willing to prescribe it if you meet the criterion of rapid progression.
Okay. Our next question is, if there is liver injury, does the liver fix itself when the drug is stopped?
In the clinical trials where elevation of liver enzymes has occurred, even the severe elevation of liver enzymes, in all cases, it's been reversible. Doesn't reverse instantly. It may take weeks or a month or 2 or more to reverse, but in all cases, it has reversed.
Okay. Next question. Why REMS for duration of taking drug instead of stopping at 18 months like they're doing in Canada? Any chance the FDA will change this in time?
Well, I don't know the reason FDA decided to continue the REMS indefinitely versus the decision in Canada to only do it for 18 months. We believe the window of liver injury is, in fact, between starting tolvaptan and 18 months. And I think the FDA is just being more conservative. Over time, depending on how things work out, it's possible that the REMS may change or evolve.
Okay, thank you for that. Next question. Can post-transplant patients take tolvaptan to slow growth of intact native kidneys?
So I wouldn't recommend that post-transplants take it. In general, the native kidneys in polycystic kidney disease decrease in size by about 30% during the first year, and many patients experience a reduction in symptoms of pain or bleeding or fullness after kidney transplant in their native kidneys. I think the risk of dehydration with a transplant kidney is probably not worth it, because I don't know that there's going to be much benefit to the native polycystic kidneys. And furthermore, no one's ever tested that. So it could in fact be harmful.
Okay. So we have a couple of questions coming up around pregnancy. Can women who eventually want to become pregnant take tolvaptan?
Yes, you shouldn't take tolvaptan if you're actively trying to get pregnant, and you should certainly use appropriate contraception if you are taking tolvaptan. But once you're off the medication for a period of time, and I would anticipate at least several months, you could consider attempting pregnancy without concern.
Okay, so I think you touched on this a little bit, but the next question was, will it affect their long-term fertility or the health of future children? So for example, if a 20-year-old wants to take this drug, would it cause issues when she's 30 and ready to have children?
It's not known to cause issues such as that. People have been taking tolvaptan for more than 10 years now. One thing I would suggest, if a 20-year-old had rapidly progressive kidney disease and they were eligible to take tolvaptan, they might be at much greater risk of losing their kidney function earlier. So that should also be taken into consideration.
Can lactating women take tolvaptan?
The FDA recommends that lactating women do not take tolvaptan.
Okay. Is there an upper age limit for who can take tolvaptan, like 70 or 80?
The FDA did not specify an age limit, but I will show you results from the Reprise study. And in the Reprise study, on the right panel here is an analysis of subgroups. And when you look at each subgroup, if it's to the right of the vertical line, it means that they did better with tolvaptan. And if it's to the left, they did worse. And if it crosses the line, it means there's no difference. And if we look at age, individuals less than 55 had a favorable effect of tolvaptan. Individuals older than 55 had a neutral effect. Now notice that the number of people older 55 are relatively small. And I believe that this is an individualized decision with the patient and their physician looking at all the risk factors, including such things as kidney size and their rate of progression. It's hard, you can't give a blanket answer. That's something that one needs to address with their physicians.
Okay, thank you. If someone has elevated liver enzymes after taking the drug, can they be given the smaller dose option, or do they immediately have to go off drug and can never go back on?
So if the elevation of the liver enzymes is less than 3 times the upper limit of normal, they'll go off drug till results normalize and can be reintroduced to a lower dose of drug with careful monitoring. If their liver enzymes go above 3 times the upper limit of normal, the drug should not be restarted.
Okay. What about pain? Does tolvaptan help reduce pain caused by ADPKD?
In the Tempo 3-4 study, patients treated with tolvaptan had lesser pain than did patients who were given placebo.
Okay. So we have a couple of questions coming up about drug interactions. Can tolvaptan be combined with other drugs? And are there any issues with doing this?
Yes, well, there's issues of certain drugs. So tolvaptan is a drug that inhibits an enzyme called CYP3A, and there are drugs that induce CYP3A, such as fluconazole or ketoconazole. So these are drugs that sometimes would require avoiding tolvaptan and sometimes would require reducing the dose. I'm hopeful that we can get a list of those drugs and make those available to physicians. So yes, there are interactions. In addition, if you look here, there's a couple of other enzymes which are involved with tolvaptan metabolism. And the FDA recommends avoiding statins and these other drugs, bosentan, glyburide, glibenclamide, repaglinide, methotrexate, furosemide. So this is the recommendation of the FDA at this point in time.
Okay. And what about people that are wanting to participate in clinical studies for other potential therapies? Would they be able to participate in clinical studies if they're also taking tolvaptan?
That's an excellent question. It really depends on the study. So in studies that are already ongoing, such as the study that Dr. Watnick and I are doing with metformin, or studies that other investigators are doing with pioglitazone or curcumin, these do not allow for a tolvaptan arm. Future studies will probably be designed with tolvaptan possibly being assigned to both groups or one group. We don't really know, but it really depends on the study, and that's something you should discuss with your study investigator. Generally, it would likely confuse the effect of the study unless the study is specifically designed to utilize tolvaptan.
Okay, thank you. Can you explain the difference between JYNARQUE, SAMSCA, and tolvaptan? And can my nephrologist prescribe SAMSCA for me?
SAMSCA is tolvaptan, but it's only approved for the treatment of low sodium levels in the blood. SAMSCA use is limited to 30 days. That is because of the concerns about the liver injury. And your pharmacy shouldn't dispense it to you for PKD. There's no support for copays or anything like that for using SAMSCA in PKD. JYNARQUE is marketed, it's tolvaptan marketed specifically for the treatment of autosomal dominant polycystic kidney disease and only available through the REMS.
Okay, thank you. Is the size of the kidney directly related to the cyst growth?
Yes. Total kidney volume is a result of the growth of cysts. As cysts grow, the total volume of the kidneys grow. And this was very nicely demonstrated by the CRISP investigators. That stands for Consortium for Radiological Imaging Studies in Polycystic Kidney Disease, led by Dr. Grantham, published in 2006 in the New England Journal of Medicine.
Okay. Does tolvaptan cause blood clots?
Tolvaptan is not known to cause blood clots.
Okay, next question. Can you just drink a lot of water and have the same effect as taking tolvaptan?
Also a good question. All of the participants in Tempo and Reprise were instructed to drink large quantities of water. It's hard to drink enough water when you're not being driven by thirst to match what you're drinking when you're taking tolvaptan. And no one has studied this over a long period. Short-term studies have been done, that is over a couple weeks, and it is possible to lower your vasopressin levels. Whether it's possible to lower them sufficiently to have the benefit that you get with tolvaptan is not known. There's actually an ongoing clinical trial in Australia looking at high water intake as a way of suppressing kidney growth.
Okay. What about people under the age of 18? Can they take this drug?
Yes, they could if they meet the criteria for risk of rapid progression.
Okay, are there any risks?
Although I will mention that tolvaptan is being studied in children in Europe. There is no study of tolvaptan in children or adolescents in the United States.
Okay, so let me ask that again. Can people under the age of 18 take this drug right now? Is it?
They can. I'm not aware of any prohibition in the label based on the
Okay.
age. But again, I'd be very careful when offering it to younger individuals because it's not been studied. And this is a question that you would sort out with your provider.
Okay, thank you.
Most people under 18 are not going to have the large kidneys that meet the criteria for rapid progression.
Okay. Next question. Are there any risks of suppressing vasopressin?
Well, remember, tolvaptan doesn't suppress vasopressin. It just blocks its receptor, and vasopressin levels are actually quite high, but they're blocked by tolvaptan. Water drinking suppresses vasopressin. If you were to drink more water than your body could get rid of, for example, if you were not taking tolvaptan, there's a risk of lowering the salt level in your blood too low.
Okay. Okay, so next question. Have side effects other than thirst, frequent urination, and the liver issues been reported?
In every clinical trial, there's a list of side effects that are associated, that are reported. Some are associated with the drug, some are not, and some also occur in the control group. But the main side effects of tolvaptan are those related to large urine output and the liver enzymes. There's, of course, a risk of getting dehydrated. If one is severely dehydrated, one might get faint or weak or have a low blood pressure. So it's very important to maintain adequate fluid intake. If one doesn't maintain a high adequate fluid intake, the sodium level in the blood will be very high, and that again will make you very, very, very thirsty.
Okay, so I'm going to go back to the 18 and under, as we're getting a lot of questions that a lot of people have heard that it's only approved in adults. And so I don't know if we need to clarify that more, or we need to have maybe more information that we post on our website about that.
Why don't we address that after the webinar?
Okay, so we'll put out something on our website to clarify if we need to. So the next question I have here is, can patients with brain aneurysms take tolvaptan?
In the clinical studies, patients with brain aneurysms that were of a certain size were excluded from participating in the clinical studies. I don't know if any increased risk having a brain aneurysm of taking tolvaptan. So it would be important to have the brain aneurysm appropriately managed and treated.
Okay. Do patients take tolvaptan up to kidney failure?
Well, people could take tolvaptan with a GFR of 25, which is not far from kidney failure. One would have to assess how the patient is doing, and that's an individual decision by the physician and the patient.
Okay, next question. Does tolvaptan reduce the size of cysts or slow the growth of them?
Tolvaptan, its initial effect is to actually reduce the size of the kidney by about 5%. That's the immediate effect, and that's presumably due to slowing or decreasing the growth of cysts.
How long can you safely take this medication?
Well, as I mentioned, people have been taking tolvaptan in all the different studies for more than 10 years, and there's been no evidence of any long-term harm. So I'm just going to show my screen again, going back to the pediatrics. Can you see my screen now?
Yes, we can.
Okay, so I've got the product package insert open, statement 8.4 pediatric use. Safety and effectiveness of JYNARQUE in pediatric patients have not been established.
Okay, thank you for clarifying that for us.
Yep.
Is there improvement in creatinine or kidney function if you start taking tolvaptan?
Actually, tolvaptan initially has an effect to slightly decrease the kidney function and slightly raise the serum creatinine as an initial effect over the first couple of weeks. And this is immediately reversible and doesn't reflect any harm. And then after that short-term effect, over the long run, tolvaptan decreases the rate of decrease of kidney function or rise in GFR, or decrease in GFR, excuse me.
Okay. What about patients that are on dialysis? Can they take tolvaptan?
They should not take tolvaptan.
Okay, and we have another question about liquid intake. So why water as opposed to other liquids? Why is that important?
Water is important for a couple reasons. So if you take liquid with either protein or salt in it, that will actually increase your urine output because your kidneys have to get rid of that extra salt or protein breakdown products. The reason to not take large quantities of other things is just because you shouldn't take quarts and quarts and quarts of artificial sweeteners and that sort of thing. And you shouldn't take quarts of sugar drinks because that will cause you to gain weight.
Okay. And what about, will cysts return or grow more if you stop taking it? So if you've been on it and then you stop, what happens?
There will be continued growth of cysts.
But they don't necessarily grow faster.
Tolvaptan doesn't stop the growth of cysts completely, right? It slows the rate of growth. There's not evidence of a rebound. You seem to go along where you would have been. Now, no one studied people going on and off tolvaptan on a daily or weekly or monthly basis. We're talking about people who finished the trial and then went on to a period of time off tolvaptan and then on to a second or a third clinical trial of tolvaptan.
Okay, I think this is an important one here. Is blood pressure medication still needed if you are taking tolvaptan?
Absolutely. Tolvaptan doesn't lower blood pressure, so you need to continue to get your blood pressure maintained under good control.
So we have this question a few times. Can you drink alcohol if you are taking tolvaptan?
You can drink safe and healthy amounts of alcohol.
All right, and let's see, next question. Do you recommend genetic testing?
I don't think genetic testing is necessary in order to determine your risk of rapidly progressive kidney disease. If genetic testing were free, we would do it all the time. Genetic testing turns out to be very expensive. And if you have typical ADPKD, there's not a large advantage to doing genetic testing.
Can doses be skipped occasionally for specific reasons?
Well, you know, you've got to live your life. When you're taking that 3-hour plane flight and you have a window seat, it's probably not a good idea to take your tolvaptan right before getting on the plane. So there are times that people need to stop it just for, you know, functional reasons. And again, whenever you're sick and whenever you have limited access to water, whenever you have nausea, vomiting, or diarrhea, or any other thing that could cause dehydration, you should not take the tolvaptan at that time.
Okay, we have a couple more, but we're getting really close to the hour, so we'll see how we do here. Are most nephrologists equipped to determine kidney volume and whether or not a patient is high risk so they can help you determine if you are a candidate to take this drug?
I think nephrologists that are interested in taking care of PKD patients and have a population of PKD patients that they take care of, I think will be well prepared to do this. I can't speak for the rest of the nephrologists, but if they don't have a lot of PKD patients, they may not have developed the skills to do this. But we'd certainly be willing to teach them.
So it seems like Nicole has maybe dropped out.
I'm sorry, I'm right here. I muted so I could take a drink of water. Sorry about that. One more question. Let me get it back here just a second. Okay. The question was, what other drugs are in the pipeline for ADPKD?
That's a great question. There are ongoing clinical trials with a drug called tesavactinib by Cadman, metformin in the TAME PKD study. Regulus is developed a clinical trial using an inhibitor of a microRNA called miR-17. There's a couple of other things in the pipeline. There's a drug called bardoxolone, which is being studied by Reata. And there's a lot of interest from different biotechs and pharmaceutical companies that we hear about all the time. So stay tuned. I think it's an exciting time for therapeutic development in PKD.
Thank you very much. That's a great question to end our Q&A session on. That is all the time that we have for questions tonight. I want to thank Dr. Perrone for the information that you've shared this evening and for answering so many questions tonight. We really appreciate all the information. If we did not get to your question, whoops, were you going to say something?
I'll just say thank you for the opportunity. Oh. Yes, send your questions in. We'll try to answer them.
Okay, thank you so much. If we did not get to your question, please know that we will be developing additional resources as more information is available. Frequently asked questions and answers are available at pkdcure.org/JYNARQUE, and we are updating this webpage as more information is available to us, and we'll do our best to add any questions that we might have missed tonight to this as well. If you would like to learn more about PKD and connect with others that have PKD, please join us in Kansas City, Missouri June 29th through July 1st for PKD Connect Conference. More information about registration is posted at pkdcure.org, and also the agenda is posted there as well. I would like to thank our audience for participating in this webinar. The webinar is being recorded and it will be available in just a few days at pkdcure.org. The PKD Foundation appreciates the opportunity to provide our audience with the best possible education. You will receive a quick survey immediately following this webinar. We appreciate your feedback and will use your responses as we develop additional resources and programs in the future. If you need to reach out to us directly, please email us anytime at education@pkdcure.org, and a member of our team will get back to you. Again, thanks to everyone for participating tonight, and I hope you enjoy the rest of your evening.